All right, let's get into it. As a trainee in gastroenterology, it's so easy to see the endoscope as just a long, flexible camera for peeking inside the body. But that's barely scratching the surface. The real magic, the future of our field, is realizing that this scope isn't just for looking. It's your entire toolkit, an extension of your own hands that lets you solve some really complex problems, all from the inside out. So in this explainer, we're going to walk through 5 major clinical challenges that, trust me, you are going to face. We'll start by completely rethinking what the endoscope is. Then, we'll jump into those high-stakes situations, stopping a bad bleed, clearing out a blockage, and even taking out precancerous threats. And then we'll talk about what to do when things, well, don't go exactly to plan.
Okay, let's kick things off with Section 1. This is all about a huge shift in how you think. We are officially moving past just being a passive observer and jumping right into the world of active, hands-on intervention.
And I'm going to say it again because it's that important. This is so much more than just a camera. You need to start thinking of it as this incredibly sophisticated instrument, packed with channels, all designed for action. The lens, it shows you the problem, but it's the channels that give you the power to actually fix it.
So let's break down what you're working with here. Think of this as your core toolkit. The air, water, and suction channels, those are for visibility. They're absolutely essential for clearing away blood and gunk so you can see what you're doing. The water jet is like a tiny power washer for the gut lining. But the real star of the show, the one you're going to get to know very well, is the working channel. This thing is the superhighway for all your cool toys, snares, needles, clips, stents, you name it. Getting a real handle on these controls is your first big step to becoming a true therapeutic endoscopist.
All right, on to our first major challenge, stopping the bleed. This is, without a doubt, one of the most common and terrifying calls you're going to get in the middle of the night. A patient with an acute upper GI bleed needs you to be fast and effective. Endoscopy? That's the front line.
So, you find the source of the bleed. Now what? The most critical thing is to figure out the risk of it starting up again. And this isn't a guessing game. We have a system for this, called the Forest classification. This table is brilliant because it tells you exactly what to do based on what you see. A Forest eye asperter is a 5-alarm fire. I mean, look at that rebleed risk, 70 to 80%. You absolutely have to intervene. And as you go down the list to an oozing vessel or an adherent clot, the risk is still pretty high, and you're almost always going to treat it. This isn't just something to memorize for an exam. This is your real-time playbook in a crisis.
Now, one of the scariest sources of bleeding is esophageal varices. These are basically a direct result of crazy high pressure in the portal system, usually from liver disease. Just picture these bulging, fragile veins right under the surface, pressurized and just waiting to rupture. When they go, it's not just a bleed, it is a full-blown medical emergency.
Luckily, we've got a really elegant fix for this: variceal band ligation. The technique is actually beautiful in its simplicity. You snap a special cap with tiny rubber bands onto the tip of your scope. Then, you find your target varix, you suck it right into the cap, and then click! You deploy a band that chokes it off. It's straightforward, it's manageable, and it's absolutely life-saving. This is a procedure you've got to master.
Okay, let's switch gears. Our next challenge isn't about a leak in the system, it's about a blockage. Could be a scarred down esophagus or, something that got swallowed and is now stuck. Whatever it is, your job is to clear the path and get things moving again. When you're up against a stricture, a narrowing, you've got 2 main plays, dilation or stenting. Dilation is basically what it sounds like. You use balloons or bougies to mechanically stretch that tight fibrotic ring. It works great for benign strictures, but you often have to do it more than once. Stenting, on the other hand, is like propping open a collapsing tunnel with a scaffold. We use this for malignant strictures or for benign ones that just keep coming back. It gives much longer-term relief. Which one you choose really depends on the cause of the problem and what you're trying to accomplish for the patient. Now, let's talk about foreign bodies. This quote you see here, this is a golden rule. The very first question you should ask yourself is not, how do I get this out? It's, do I even need to get this out? A surprising number of things people swallow will pass on their own. Jumping into a risky retrieval procedure when it's not necessary is just bad medicine. Your clinical judgment here is everything.
But there are some situations that are absolute non-negotiable emergencies. This list right here, these are your red flags. If a patient can't even swallow their own saliva, that's a complete obstruction. Sharp objects could perforate the esophagus any second. And button batteries? Oh, they are a special kind of nasty. They create an electrical current that can literally burn a hole through the tissue in just a few hours. And multiple magnets can trap a piece of bowel wall between them and cause it to die. When you see any of these, you act, and you act fast.
Okay, so far we've been putting out fires, right? Reacting to crises. Now, let's talk about fire prevention. In this section, we're not just fixing a problem that's already happened. We are actively getting ahead of a potential disaster by finding and removing lesions before they have a chance to turn into cancer.
And our main tool for this is endoscopic mucosal resection, or EMR. This procedure is a total game changer. It lets us take out these large, flat polyps or even very early cancers without the patient having to go through major surgery. It's a minimally invasive revolution, and it has completely changed how we handle these early GI lesions.
And the technique itself is just so elegant. It's like a three-step dance. First, you inject. You slide a needle through the scope and inject a saline solution right under the lesion. This creates a little safety cushion, lifting the bad tissue up and away from the deeper muscle layer. Then you suction and snare. Using a cap on the scope, you suck that lifted lesion in and throw a wire loop, a snare, around its base. And finally, you resect. You pass an electrical current through the snare and it cuts the lesion off cleanly. Inject, snare, resect. It's just a beautiful way to remove the disease and save the organ. So, we've talked a lot about what to do when things go right. But look, every procedure we do has risks, and a massive part of your training is learning what to do when a complication happens. This isn't just about your technical skill. It's about being prepared, being a leader, and communicating clearly. Let's be really clear about something. Therapeutic endoscopy is incredibly safe. But bad things, like a perforation or a bad bleed after the procedure, while they're rare, they can and they do happen. The sign of a true expert isn't that they never have a complication. It's that they are 100% prepared to recognize it and manage it the second it happens. Complacency is your worst enemy here. This is a masterclass in how to handle a crisis. Seriously, every trainee should have this script practically memorized. Let's break it down. First, you're direct and honest. We have a perforation. No sugarcoating. Second, you immediately refer back to the consent process. This was mentioned as a remote possibility. Third, you show empathy. You show you're human. I'm sorry that it has occurred. And finally, you take charge and project a clear plan. This is what we need to do. That is how you maintain trust and control a really difficult situation. So what is that plan? Here's your checklist. First up, you have to act fast. Delay is dangerous, both for the patient and for you. Second, get help. That means ordering the right scans and getting your surgical colleagues on the phone early. Third, communicate. Keep the patient and their family in the loop. And finally, show you care. The absolute worst thing a patient can feel is abandoned after a complication. You have to stay involved.
We've covered the big challenges you're going to face as a trainee right now. But this field, man, it is moving at an incredible speed. So let's wrap up by taking a quick look over the horizon at what's just around the corner.
The future is just wild. We're now working in what's called the third space. That's the layer underneath the gut lining, doing these crazy complex procedures like ESD and POEM, which are basically surgery inside the wall of the GI tract. We're exploring something called notes, where we use the scope to actually leave the GI tract and operate in the abdomen with zero skin incisions. And of course, AI is coming, acting like a super smart partner that can spot tiny lesions we might otherwise miss. We're even seeing the rise of bariatric endoscopy as a less invasive option for weight loss. The pace of innovation is just relentless. So, as we wrap this up, here's the bottom line. The endoscope is just a tool that's getting smarter, more powerful, and less invasive every single year. But the real progress, the real innovation, that comes from us, the endoscopists who use it. The next big leap forward isn't going to come from a lab somewhere. It's in your hands. So the real question for you isn't just what procedures will I learn, it's what new ground am I going to break? What will you pioneer?